Welcome to Epilepsy Management and Beyond. My name is Donna Avanecean, and I will be your presenter today. Welcome. So if you have not already viewed my previous presentation, circuit breakers and epilepsy, please do so as I go into more depth about the diagnosis of epilepsy and provide you with a overview of treatment. Today's presentation will be focusing on medical management and surgical management of persons with epilepsy. So to begin, I'd like to share a little information about myself. I have over 30 years of neuroscience experience. I have various subspecialties, including neuro-oncology, neurovascular, epilepsy, and movement disorders. When I'm not functioning as an APRN provider at the Epilepsy Center for Ayers Neuroscience Institute, my other hat or role is the current director for the Hartford Healthcare Medical Group Advanced Practice Providers Specialty Division. I provided you with my email address, and please feel free to contact me directly if you have any questions or recommendations. Fun fact, I always like to also add a fun fact about myself. Fun fact is that I am now learning how to sew after many, many years and finding it extremely relaxing. Okay, so for the objectives for today's presentation, we're going to be discussing the medical management of patients with seizures and epilepsy. We will specifically address the criteria for considering individuals for surgery. And then finally, we'll summarize with the surgical management of epilepsy. I have nothing to discuss. So now we're going to be moving the remainder of today's discussion into epilepsy. Start off with discussion around the purpose of epilepsy surgery. So understanding that epilepsy has a major impact on individuals' quality of life. Many of them cannot hold down jobs because of the number and amount of seizures that they're experiencing, or the side effects that they're experiencing from being on multiple medications. Many of them, because of either their EEGs or frequency of seizures, are unable to drive. This has a lot of impact on their quality of life. So when you have reached a point where a patient may be on 2, 3, 4 anti-seizure medications and are still having frequent seizure breakthrough, you want to start to think whether or not your patient would be an excellent candidate to have epilepsy surgery, with understanding that you're either going to eliminate the seizures or at least greatly reduce the seizure burden in the individual with drug-resistant epilepsy. Now, drug-resistant epilepsy, by definition, is when you have failed 2 or more anti-seizure medications. And one of the things that I also failed to mention when we were talking about some principles of medication prescribing with individuals with epilepsy is that our goal is always one agent, because that's where you're going to achieve the maximum reduction of seizure burden. By adding a second agent, you may reduce your seizure burden by 85%, although there's a lot of epileptologists that would say it's even lower than that. And by adding the third or fourth agent, you probably are only going to appreciate anywhere from an 8 to 15% seizure reduction. So adding more medications is not necessarily going to yield a good goal or objective. So, the purpose of epilepsy surgery is to improve quality of life and to either eliminate or greatly reduce the seizure burden in individuals with drug-resistant epilepsy. Now, if you were to look at two major types of surgery that we talk about in epilepsy, the first is resective surgery, and we'll discuss all the different types of resective surgery that are available to our adult patients as well as children with epilepsy. And the second category, if you will, is neuromodulation. Now, surgical decision-making, I already started to talk to you about. I said there's a committee. Well, there is a committee that comes together depending upon your organization. Our group meets weekly, and it's a multidisciplinary case conference. We have neuropsychologists, neuroradiologists. We have our neurosurgeons who primarily perform epilepsy surgery, our social worker. Obviously, the epileptologist is the person who is presenting the case, and we all get together and we discuss and review every single source of information. There is usually a hypothesis. I've mentioned this before. There's a hypothesis based on the patient's seizure presentation, their semiology, where we hypothesize the focus of the seizure activity is coming from. That's the hypothesis that is developed. The overall time that it takes from the time that we make a decision that a patient is a surgical candidate to the time that they actually at least have the epilepsy surgery, if not the intraoperative, the electrode, the depth electrode, or the subdural grid recordings, is about 6 months. So there's a lot of back and forth. There's a lot of delay. Some of this is patient related. Halfway through the workup, they'll get very nervous and they'll say, "I don't want to do this anymore," which is fine by us. And then later on, a couple of years later, they're saying, "Okay, things have gotten better. I'm ready to proceed." And sometimes that means that we have to start the whole surgical workup over again. So once we decide that a patient is a surgical candidate, and let's say we have decided, okay, all of the seizures are coming from either the frontal lobe or the temporal lobe. We have identified that it's in the non-dominant hemisphere for the majority of us who are right-handed. That's good. The non-dominant hemisphere is going to be the right side. But for the majority of right-handed people, the left side is going to be the dominant side. So we have this patient, their seizure semiology and their MRIs and everything is showing us that the seizure focus is either coming from the temporal lobe or the frontal lobe. We can actually now go in and remove that focus of tissue, and that's known as resective surgery. And there's two types that we primarily use in adults. We use temporal lobe resections and we use frontal lobe resection. So let's talk about some of the subtypes of surgery that we can perform. So as I said, we can either go in there and take the anterior 2/3 of the non-dominant temporal lobe out in the hopes of either stopping the seizures altogether or greatly reducing them. But it doesn't stop there. There are other types of temporal lobe seizures that we also can employ. Specifically, if we're seeing that the seizure focus is either coming from the amygdala, which is very in close proximity to the hippocampi, the neurosurgeon can actually do a super selective resection of the hippocampus and the amygdala, preserving the lateral temporal cortex. There is also the neocortical temporal lobe surgery, which is the removal of areas of the temporal lobe's outer cortex. And finally, the least invasive type of temporal lobe surgery that can be performed is something known as LIT, laser interstitial thermal ablation. And this is a minimally invasive procedure, as I've said, that uses a laser to destroy small areas of the brain tissue. And if done right, this really can be a game changer for patients. A lot of times it can be used in those individuals with mesial temporal sclerosis. It can also be used if the patient only has a couple of heterotopia. There are patients, when they are born with heterotopias, they are born with numerous heterotopia, in which case we couldn't go in there and laser each one of them. So it can be used also for that. And I believe also can be used for individuals who have cortical dysplasias as well. Now, another type of surgery that can be performed, but generally not in our adult population, this is reserved more so for our pediatric population, is something called the disconnection surgery. And the goal of this type of surgery is to actually go in, the neurosurgeon goes in, and they disconnect the white fibers known as the corpus callosum. So the corpus callosum is a band of white matter fibers that allow for direct communication between the right hemisphere and the left hemisphere. And so if you have individuals where the seizures start in the right hemisphere and quickly radiate over into the left hemisphere and that they are intractable, the neurosurgeon can go in there and actually cut those white matter fibers. Now, that is not going to cure their focal seizures, but rather we're not going to have that secondary generalization, and you'll still need to treat the focal epilepsy. And as I said, this is seen in the pediatric population. Also in the pediatric population, we're able to do another procedure known as MST, or multiple subpial transections, which is a series of shallow cuts in the cortex. And that allows for spread of seizures. And then finally, the most aggressive is hemispherectomies, where there is surgical removal of the hemisphere that is involved. And so here we have a cartoon that's showing the corpus callosum. So they're able to go in through usually the longitudinal fissures, and they're able to cut the corpus callosum, cut those white fibers right here, okay? The MIST, or MST, is where they are making those shallow cuts through the cerebral cortex to help with the spread of seizures. And then finally, we have what's known as a hemispherectomy. Very, very aggressive treatment or surgical treatment. This will render the child hemiplegic. And if the dominant side, of course, is resected, then the patient, the child will lose speech ability. So very radical treatment. Now let's shift our focus to neuromodulation. So the first type of neuromodulation, and probably the oldest one that is out on the market, is what's known as our vagal nerve stimulator. So vagal nerve stimulator is there's an electrode that is implanted at the neck. It's attached to the vagus nerve, and it's connected to a generator in the chest, similar to that of a pacemaker. And the function of the VNS, it provides stimulation of the vagus nerve, which can help to reduce seizure burden. The device requires programming in an outpatient clinic to deliver pulses or stimulation at regular intervals. And so usually this is a one-day procedure. The patient is admitted to same-day surgery. The neurosurgeon will go ahead and make a small incision. We'll insert the electrode and attach it to the vagus nerve. It is then fed underneath the skin area, and the generator is placed. The device is still not turned on. The patient then comes to see us in the neurology clinic, and we will begin to program the vagal nerve stimulator. That is accomplished through a wand that receives information directly from the generator. And there is a tablet, and we're able to change the amount of impulses that the patient receives. The battery life or the generator life, depending upon how high our settings are, can last up to 5, maybe 6 years. The higher the cycles of stimulation that are provided to the patient usually will drain the battery. And that is something that we always assess for at each visit. So at every single visit, outpatient visit, we will always interrogate the vagal nerve stimulator. Depending upon seizure stability, we either just continue the settings at the same settings. Otherwise, if there are more seizures and there are capability of the patient having either a decrease in the time intervals between the stimulation being given, or we can increase something known as the duty cycle, which is a more rapid cycling of the impulses that get delivered to the patient. The patients also will receive a magnet that they can swipe over, or their loved ones can swipe over during the time of the seizure to give them an extra stimulation in order to stop the seizure. So that's the vagal nerve stimulator. Usually very well tolerated. You know that the device is working because it will, the quality of the sound of their voice will all of a sudden, they'll sound very hoarse. And that is because the vagus nerve innervates our vocal cord. So every time they receive a stimulation from the device, the voice will change. Some patients, when you use the magnet, because the magnet is preset to deliver a higher impulse, usually around the same amount of time that they do get the impulse as when it is generally working. And some patients will cough when you use the magnet. To avoid that cough, we tell them that after we have made adjustments to their vagal nerve stimulator, that on a daily basis, just once a day, just swipe with their magnet, and eventually they will get used to the settings. So again, that is our vagal nerve stimulator. Now, the second type of neuromodulation I wanted to discuss is something called responsive neurostimulation, also known as RNS. So this is another implantable device that detects and responds to seizure activity, while also delivering stimulation to prevent or reduce seizure occurrences. Now, it works in 3 ways. And I think this is what makes this device really neat. The first is, once it has been implanted by the neurosurgeon, it will first begin to collect data on the patient's brainwaves at the seizure focus throughout the day, and that includes during sleep. That information, after a period of time of several months, either 2 to 3 months, is getting uploaded to a central repository so that we have all of that information on the patient. Now, seizures could be occurring also during this time. We're getting that information about those seizures. It will detect any unusual electrical activity and make note of it. And then finally, it will respond within milliseconds, once it's been programmed, to seizure activity by providing small bursts of stimulation in the hopes of reducing seizure burden. So again, we have some cartoons here showing how the device is implanted. There is the generator, if you will, and usually the electrodes are implanted deeper in, depending upon where the predetermined areas within the brain matter. So if the seizures are coming from this area, then the electrodes are placed here and the device is placed under the scalp. And this is what it looks like in the operating room, and this is what the device looks like. And then finally, this is the iPad, if you will. The patient receives the wand, and they have an app that they use. They place the wand over where the device is located. The nice thing is that once they start their interrogation, the device will tell them whether or not they're in the correct area, but most patients very quickly will become experts at where their RNS is implanted. The information then gets uploaded. We then work with the electrophysicist, who then aids the epileptologist in determining the programming for the device. So that, in essence, is the responsive neurostimulation RNS. And then finally, we have deep brain stimulation. Many of you are already probably aware of deep brain stimulation. It was initially established in the treatment of Parkinson's disease, essential tremor, dystonia, and obsessive compulsive disorder. In 2018, the FDA granted its usage in epilepsy. It's designed to modulate how brain cells or networks work by delivering electrical stimulation to brain areas involved in the seizure focus. Similar to the vagal nerve stimulator and RNS, it requires programming with a handheld device. DBS will primarily affect the excitability of certain circuits in the brain, targeted to prevent seizures from occurring. They actually say that it can also cause some remodeling of the brain tissue in that area and can be quite successful. We also have patients who have initially had a vagal nerve stimulator and then maybe did not get the effectiveness we had hoped to with that device. And then we later on will put in a DBS. And what they have been finding is that with the combination of the two, it has achieved better seizure control. So I think that's pretty neat and exciting. So in conclusion, I want you to come away with some takeaway points in regards to epilepsy surgery. Unfortunately, it is not useful. Not every patient is an epilepsy surgical candidate, unfortunately, and this is independent about whether or not they're intractable or refractory to standard medical management. It requires a very thorough evaluation, including assessment of patients' social support. And the overall benefits from epilepsy surgery include reduction in seizure frequency, improved quality of life, and reduced need for medications. I wish to thank you for your time and attention, and I hope that you have found this presentation very helpful. You have my email address, and I really do value any feedback that you can give regarding this presentation or any other future presentations you would like to hear.